We have a great talk coming up, ENT, where to refer or not to refer, and I guess with the lack of access to ENT, which is coming up, it's really good for us to know, when should we be referring to our ENT surgeons. I'd like to thank Epworth for sponsoring this part of the session, and to remember to pop out and see Epworth. Have got a table out there, and I know Jackie, she's lovely, so it's worth going to see her. And also there's health pathways relevant to this session. I would like to introduce our speaker, Mr. Mark. Guirguis. I should have checked. Mark has been in private practice since 2005. He's based in Ballarat. He holds appointments at 4 public hospitals, both regionally and Metro Melbourne. He must be a busy man, with academic appointments at 3 university medical schools. His role of head of unit at Grampians Health Service, and he still takes calls for on-call for ENT emergency. And I just asked him a surfing era question, and he just gave me a very good answer. And so over to you, Mark. Thank you.
Okay, thanks very much. That was a nice introduction, thank you. And it's actually very good to be face to face again after all these years of having to do Zoom sort of chats with people. And it's good to be amongst the GPs, because I always used to love going to, in Ballarat they used to have a golf weekend with all the GPs, and I used to really enjoy getting all the gossip and all the darts thrown at me from the GPs at that golf thing, and now I'm too busy for that, so I can't do it, so it's good to be here again. So I presume that the reason I've been asked to do this is because it's so hard to get an ENT appointment, and we get lots of maybe mildly angry letters from GPs, with saying this is now the 4th time I've referred this patient to clinic and they're still waiting, and so it's good to sort of have a chance to sort of really, discuss this, I think. I didn't intend this to really be much of a didactic talk. I was really hoping it would be an opportunity to sort of get a feel for how you guys can make suggestions to try and manage the ENT workload. Because when I checked with the ENT nurse in our clinic at the base hospital in Ballarat yesterday, and as of yesterday, there were 3,054 patients waiting for an appointment in ENT. I should just say this should be Chatham House rules. I don't want the Herald Sun to be quoting me on this, if that's okay. But so 3,054 patients are currently waiting for an ENT appointment. We're currently seeing about 30 patients per month, new patients. So you can do the sums. The longest waiting patient has been waiting for 2,256 days. There are over 500 patients with tonsillectomy awaiting an appointment, and we haven't seen a single Category 2 patient since the COVID restrictions were lifted, and the current waiting time for a Category 1 patient, which is like a cancer or something, is like 3 months. So that's Ballarat, and we have worked very, very hard. I've worked very hard with Jenny Ferguson in Ballarat to try and streamline the outpatient appointments, and I actually go through all the triaging myself with the registrars. So that's with a lot of the fluff, what I'd call fluff, taken out. They're the sort of numbers we're dealing with. And and I know I'm on these sort of statewide panels for trying to sort this situation out as well. And I know Bridget Clancy Warrnambool not seeing new patients. A lot of the guys in Geelong not seeing new patients. No public service in Bendigo. So it's not a great situation. So I'm really I sort of titled this a fireside chat because it's not really meant to be me telling you guys what to do and you telling. I'm really looking for some advice and input and where you think the situation can be improved. So obviously the challenge is trying to sift through who needs to see us and who can be managed, and in a way sometimes this talk I think can sometimes be not really a medical talk, but more of a philosophical / moral / political / social talk, because I get the pressure. I get the pressure that as frontline medicos you're under, and obviously you've got patients coming to you, and they come, you say, "Oh, we'll send you to an ENT," and they come back, because they haven't seen anyone for 3 months, and they come back again, and and that whole situation. So I thought I'd sort of pick on 3 sort of common themes that I see in terms of referrals to the clinic and to the rooms, by the way. So that's the public system, and I should say, because I've just been in ED this morning in Ballarat, so I've just had the ED AO give me a mouthful as well. So don't mind, don't be afraid to sort of throw a few darts at me, because I'm sort of used to getting it. But so in private practice, I probably booking out to about January now for appointments in my rooms. And I always think, oh, maybe that's because I'm not working hard enough. Well, I'm doing 10 sessions a week. I do 1 in 3 on call, and I'm operating all those hospitals, so I'm not sure there's too much more room to move. But so it's really becomes a question of how we're going to manage the situation. Really, it's sort of like I sort of feel like we're all on the battlefield together, and we've just got to try and there's this tsunami of patients that we've got to try and sort of figure out. So in terms of the themes of referrals that I think we get, I think probably number 1 would be otalgia. And that takes when I say otalgia, it's like that can take the form of recurrent middle ear infections, eustachian tube dysfunction, other causes of pain, headache, hearing loss. When I say otalgia, it all sort of fits into that category of ear stuff. And really, from our point of view, really what we're trying to figure out is this otitis media with effusion? Because really, do they need grommets, basically? Do they need grommets? Have they got a cholesteatoma? Have they got something that requires surgical intervention? Or is it just something else? Is it something else that, we're just going to manage them as much as anyone else can manage them, that not really is going to lead to a surgical sort of outcome? So, I think one of the themes I've got with this talk is, all right, what are the things that you need to do probably at a GP level to try and sort it out? Someone comes to you, I've got sore ears, or I've got a blocked ear, or I can't hear, or I've got this pain, or usually what they'll say is I've got an ear infection, or I've got a sinus infection, or I've got a tumour in my throat. They'll come up with a diagnosis, and you've got to try and sort it out. So I think our biggest bugbear is not having an audiogram. So, I would say when I do the referrals, there'd probably be at least 50% of referrals for hearing loss don't have an audiogram. And in Ballarat, that just gets rejected. That referral gets rejected. Because, you sort of need an audiogram, because subjectively, it's not sort of helpful if the patient says that, they can't hear, but then you do an audiogram and they've got perfectly normal hearing. So that gives us a lot of information, and again, I understand the pressure, because then there's this whole trouble actually getting the audiogram. It's probably, but I think it's easy to get an audiogram, it is to get an ENT appointment. So, and so send in the referrals with an audiogram for any sort of ear-related problem, and that includes, dizziness, hearing loss, blocked ears, recurrent middle ear infections. Basically, if it's an ear problem, get an audiogram, because I think that would be, very helpful, because we can screen pretty quickly exactly someone who's got a problem and someone who doesn't. And our big bugbear again with audiograms, which I'm sure as GPs you're in a no-win situation, is the old classic asymmetrical sensorineural hearing loss, ENT referral essential. And it comes down to, what is a significant asymmetry? Because, I always say when I teach the medical students, I say, look at the audio from sort of 3 metres back, right? And if you can see, if they look different from 3 metres back, that's probably significant. But if there's like 5 decibel discrepancy in one hearing loss, that is not an asymmetrical hearing loss. So, that there's sort of, what we do in Ballarat now is really the question is, have they got an acoustic neuroma? And so what we do now is we don't see those patients, we just get an MRI. And if the MRI is normal, that referral will get rejected. And, you know, again, I'm open to input, whether that's right or wrong, or can or can't, or we shouldn't do that, because, you know, I read the report from the audiologist and they say ENT, appointment essential, or must be cleared by ENT surgeon or something. But, you know, and that's sort of the issue. So get the audio, and if the audio is normal, then I guess the question is, why have they got the symptoms? Because if there's a problem, the audio will be abnormal. So if the audio is completely normal, why have they got the symptoms? And I, you know, what we see a lot of, and certainly in my private practice, what I see a lot of is blocked ears, is eustachian tube dysfunction, which I tell the patient is actually not an ear problem, it's a nose problem. So that straight away takes it out of the ear category into the nose category, and they sort of go, oh, actually, yeah, I've got stuffiness, and yeah, I've got a blocked nose, I can't breathe, brother. And the other big one that we see is TMJ dysfunction. So, you know, I send just about every ear patient I see, you know, ends up going to see a myotherapist, because most of them have got TMJ dysfunction. So, you know, completely normal audio, you can rule out just about anything sinister going on with the ear. So, you know, I think that would get rid of about 90% of ear patients. So again, I'm open to, you know, suggestions, but you know, because I understand the pressure. If they've got a completely normal audio and they say, oh, they've got tinnitus, they've got pain, they've got this, they've got that, but, you know, they're holding up an appointment in the outpatient clinic. They're one of the 3,000 that are probably going to get it seen in 10 years, you know. So they're just sort of things that I think are... So the number one thing for ear problems is audiogram. The next little, you know, sort of joy is headache/facial pain. And again, the patient doesn't say they've got headache, facial pain. They say, oh, I've got sinusitis. And you say, what do you mean by that? They go, oh, I've got this pain here, I've got this pain here, I've got this pain here, I've got basically anything on their head is sinusitis. And again, in Ballarat, if you send a referral into clinic with, you know, can you manage this patient with sinusitis? No CT, rejection. Okay, you don't get an appointment unless you've done the CT, and ideally the CT is abnormal. You know, like, because a bit like with the audiogram, if the audiogram's completely normal, you know, they're going to go onto the never waiting list, and if the CT is completely normal, they're also going to go onto the never waiting list, you know, for an appointment. So if the audiogram's normal for an ear problem, if the CT is normal for a nose problem, they're probably not going to get an appointment for, you know, 5 years, 10 years. So again, the question is, why are they getting the facial pain, you know, headaches, you know, my sinuses, I've had 26 sinus infections this year. It's probably TMJ, it's probably myofascial pain syndrome. So again, you know, if they've got a straight septum, normal looking turbinates and completely normal sinuses, you know, when they say they're getting headache and facial pain, it's not their sinuses. Or, you know, the other one I sort of love is when you know, we get this thing saying, oh, I'm getting a headache from my sinus up here, and you look at their CT, they haven't even got frontal sinuses. You know, they've got their frontal sinuses haven't formed, and they say, I keep getting sinusitis up here. And so ideally, someone sort of looked at the CT before they send in the referral and realise, you know, it's not their sinuses. So, you know, we sort of, again, myotherapy, stress management, TMJ dysfunction, those sort of things. So that's another big cohort. So I'd say it's probably about a third of them are ear problems, a third of them are these headache, facial pain, and a third is you know, that old chestnut of globus. So I've got a tumour here, I've got a lump here, I can feel a lump here, usually what they say, I can feel a lump right here, and what they're feeling is their thyroid cartilage, you know, so again, I think probably not a bad screening test is to do a CT, because one of the challenges we find with globus is the patient, and we'll get onto this in a tick, the patient comes in and says, I've got a lump here, and usually the first test the GP orders at that point is a thyroid ultrasound. And what that does is it sets them off on onto the whole thyroid pathway, which is just a really fun pathway with thyroid nodule 3 or thyroid nodule 4 and a 6 millimetre thyroid nodule, and they must be seen because it says on the report it could be cancer. And then they write to the minister because they haven't been seen for 3 years, because they've got cancer in their thyroid, and it's a 3 millimetre nodule. So globus is really what they're talking about when they say they've got a lump in their throat, and you do a CT, it's normal. Why do they still feel like there's something in their throats? It's probably because they've got mucus build up in their throats and they've got globus symptoms. And again, I guess you could argue that we could do a scope. Just they're patients we often see once. We just do the scope. We say there's absolutely nothing wrong there. CT's normal. Done the scope. Everything's normal. There's really there's nothing we can do surgically. But typically the scenario is that they had sort of a lump here, and then they go and have their ultrasound, and it shows the nodule on the opposite side, the contralateral side, which is they've come in now. They've got this suspicious thyroid nodule, and they've had 3 FNAs, and we're following it with serial ultrasounds, and they have a sort of thyroidectomy. And I note, when I first went to Ballarat, I used to see all the thyroid nodules, and that was like 5 thyroid nodules a day with all these patients. And now there's a couple of thyroid guys that have come to Ballarat, and so they all go to them first, and then they have their thyroid out, then they come and see me with their globus symptoms. And so, now we're seeing all the ones who've had a total or hemithyroidectomy and they still got this lump in their throat. So these are all, as I say, the question really is sort of philosophical, how do we manage these sort of problems? Because what we're really trying to do is screen out the ones that are, really got something seriously wrong with them or something that needs surgical intervention versus the ones that don't. So, it's sort of, and it's a difficult situation. I'm always looking for input as to what we can do, Yes, and I'd like this to be a discussion if we could. So that yes.
Where's the microphone? We need the mic. Because we've got online, we need a microphone because we probably...
The online people can't hear. Who was it? I missed... Oh, right.
Questions at the end.
Oh, really? Okay, all right. Okay, all right. Okay. Because I've nearly finished the didactic talk, so I want sort of it to be half an hour of discussion. So, do you want me just to finish, or do you want to just take the question quickly?
Sorry, I'm just going to quickly ask, out of this cohort, who would you suggest needs a nasal endoscopy for the cancer question? Yeah,
I've got sort of the ones the red flags, if you like. So I think we're asking, what are the red flags? So for ears, it sort of seems intuitive. Some of this might be very, very obvious, but red flags, facial palsy. Somebody comes in, I've got an ear infection and a facial palsy. Well, that's not itchy ears or eustachian tube dysfunction. Clearly there's something going on. But again, we still see a lot of patients who have had a facial palsy for 8 months. And it's been called the Bell's palsy, and it's only then that they sort of get to see us. So if you wrote on your referral, this patient's got an abnormal audiogram and a facial palsy, they wouldn't be waiting 3 years to see us. They'd be seeing us in 2 weeks. Similarly, if you do the audiogram, they've got a sudden sensorineural hearing loss. So their hearing was perfect, a week ago, and now they've got a very significant hearing loss. They again will probably be seen quite quickly. And obviously when you look in their ears and they've got the whole pin is red and inflamed and painful and discharging, again, those patients will be seen quickly. They're not going to be waiting for 3 years. So they're sort of red flags for ears. For nose, periorbital cellulitis. So the patient who comes with a swollen eye, and that's actually not an eye problem, that's a sinus problem. So you need to do a scan of their sinuses. Visual disturbance or limited range of movement. Now, if you think about it, I'm not sure how many times you've seen that in your practice, but we would see it very, very rarely. So of the 3,000 patients that are waiting, there's probably 5 patients out of that 3,000 have got any of these symptoms or any of these signs. So So periorbital cellulitis, I think that's really important. Visual disturbance or limited range of movement of their eyes. A really good little trick for anything that's really bad sinus related is infraorbital nerve. It's a big nerve, and you'd be surprised, if they've really got serious pathology in their sinuses, they'll have paresthesia of the infraorbital nerve. So just check their sensation, in the maxillary region, and that's a red flag. So if you're at a referral saying this patient's got sinusitis and diplopia, they'll be seen quickly. If you say I've checked their infraorbital nerve and they've got paresthesia of their cheek in the setting of an abnormal sinus CT, then they'll be seen quickly. And again, the throat, just getting back to your question, I think compromised airway. So stridor, they've got stridor. Clearly, that's an issue. Loss of weight, trismus. If they've got actually nodal disease and the globus symptoms, I think that will get seen quite quickly. So any referral that's got any of these things, they'll be seen in 2 weeks. They're not going to be waiting for 3 years or 8 years or 2,256 days. But obviously it's a partnership because we're incumbents on the referral letter. We're really relying on the referral letter. So the referral letter that says, can you please someone who's got a sore throat, and then 20 pages of blood tests that they've had over the last 8 years. That's it's not sort of helpful. But these are sort of red flag things that we would look for, but there's not many of those. I mean, I don't know what you feel as a group, but there's not many that would have any of these sort of signs and symptoms. So the challenge, I've just put a few slides. The challenge is, well, how are we going to sort it out? Now, I don't have any affiliation with Voritech. I don't know if Voritech are the guys who make the voroscopes. But Geelong, it's quite appropriate in Geelong. Geelong's the home of Voritech. This is a worldwide thing that's revolutionised ENT examination. I don't think it's a big ask. I mean, don't shoot me, but I don't think it's a big ask if you've got a practice of 20 GPs to spend, $1,000 or whatever it costs for a voroscope like this. Because 2,000, is it? 300. How much?
Over 2,000.
2,000. All right, 2,000. But anyway, 2,000. So I don't know how much a blood pressure machine costs. But you probably got 10 of those. But this is the difference between seeing what's going on and not seeing what's going on in ENT. I don't think you can really examine any ear, nose, or throat problem without appropriate lighting and appropriate magnification, and that's really the biggest secret. I mean, you send them to an ENT, we've got that. That's probably the only difference, really. I don't use the headband like this, but I use spectacle-mounted ones. But they are individual. But a headlight like that is, you shared with everyone in the practice, and that's, I would think if I was running a general practice and I saw any sort of children or any ear, nose, and throat problems, that's going to make a big difference. Again, no affiliation, no conflict of interest at all, but that's just my opinion. So the advantage of the voroscope, when you're looking at the ears, you get to see the whole drum. So I've just even when I know exactly what's going on, I cannot use one of those otoscopes. I go into ED, and if I've left my voroscope at home and I've grabbed the otoscope they've got in every cubicle, even if I know the pathology, I still can't see what's going on with the otoscope. I've just never been able to. So you need to see the whole drum. You need to see exactly what's going on. The nose, my little bugbear with every single patient's on anticoagulation now, and so everyone that's on aspirin, clopidogrel, and warfarin is going to get epistaxis. With the voroscope, you can just have a really good look in the nose. You can actually look at the septum. You can actually look at the turbinates. You can suck out the clot when they come in with epistaxis. I don't think I'd be able to manage an epistaxis patient without an appropriate headlight like that. So I don't know how they're managed in general practice land without a headlight like that. Again, voroscope, you get a really good look at the tonsil and tongue base. So again, I'm an examiner for the medical students, and anyone that comes with neck nodes, they always have this OSCE station with neck nodes. You know, and I say, if you've got a cervical neck node and you have not looked in the mouth, you can't pass the OSCE, right? You just can't pass. And they sort of stare at me and think, right, you're a freak. But the number of times that we see patients with, I've got this guy with a bit of a lump in the neck, and they've got a fungating, tonsil cancer or fungating tongue cancer or a massive ulcer or, So the voroscope allows you to sort of have a look in the oropharynx properly, look at their tongue base, their tonsil. Because basically, 80% of the SCCs are going to be either tonsil or tongue. Don't think you've missed that sort of tiny piriform fossa, thing that's 1 millimetre. I mean, you don't really see those much. So most of them are going to be tonsil or tongue cancers, and they're easily examinable with appropriate light source. So, and then I've just put here what you don't need the voroscope for. So what you don't need. So is mastoiditis. So that's one of our little, chestnuts, lovely chestnuts for ears, is the radiology report that says they've got mastoiditis, which to them means they've got any sort of opacification in the mastoid air cells, which is different to what I call mastoiditis, which is the boggy, septic, red, pus-filled, thing that you can just feel. You can feel the mastoid process, and that. If they've got discharge from their ears and they've got a really boggy, soft mastoid with an abscess that's red, that's mastoiditis, not one cell of their mastoid air cells that's got opacification. So, and again, what you don't need the voroscope for, and what you don't need a CT for, and what you don't need extensive investigations for, is a fractured nose. So again, that's the other one that sort of we get all these fractured noses. Basically, the management of fractured nose is very easy. They fracture their nose. Don't do anything for 10 days, see them in 10 days, and then if it looks abnormal, then send them into ED to sort it out, because we're not going to do anything for 10 days till all the swelling subsides. And I've said there, looking in the throat, most people, that's the only thing you probably can look at with the torch is just, look in their mouth, look at their tonsil, look at their tongue. So they're the sort of important examinations that you don't need a voroscope for. And that was sort of, the end of my didactic talk, but as I say, I was hoping to get some. I'm hoping to get some feedback from the room in terms of what the feeling is out there.
Thank you. I think it is. I think you will get lots of questions because we've got it. So I think we can ask any question. We've got one over here.
So I'm Michael Homan. I'm a GP. I worked as a clinical assistant in ENT outpatients for about 3 years.
Yep.
And at that stage, it was with John Voris. I walked out with a voroscope. And our practice then has a voroscope, and I must say, I think I agree, it's a really important part of general practice. They are expensive, but at least the newer ones are multi-adaptable for people's eyes, so it can be shared amongst the clinic. And for otitis externa, cleaning out ears, it just makes it so much easier. They are expensive, but I think they're a worthwhile investment. But maybe one of the solutions is to get more GPs involved in outpatients, and maybe that's something that the PHN could look at, doing rotations through outpatients, because that's certainly how I learnt a lot, and I was able to pass on my knowledge to the people in the clinic that I worked with, about 10, 12 doctors. Yep. So I think, we need to look at the big picture. You're talking about a whole lot of things that can generally be managed in general practice, but we need the support, we need the ability to be well tutored, and outpatients was a fantastic way to do that.
Yeah,
thanks.
Great. Yeah, that's a great suggestion, and I think we're always we'd be certainly open to that suggestion. And the only thing I would comment on is that I'm hopeful that because we're so tight with our streamlining of referrals, we're actually seeing that tiny tip of the iceberg that actually have got the pathology, as opposed to the 3,000 patients that have got sort of nothing wrong with them. But yeah, so what you're seeing in outpatients is, if it's all working properly, is the real the real pointy end of the ones that have actually got something serious wrong with them, rather than the fluff, But it's a good suggestion, because it's really it's sort of the bottom of the pyramid that's the issue. It's as they present to you with 3 times with sinusitis or ear infections or whatever. That's the.
Deb Harley, GP. We used to have a whole lot more shared care experience in Geelong anyway, in the old days, with GPs that worked in outpatients but ENT was one of them. But I think that a lot of your time could be saved by educating the GPs to use health pathways more efficiently, because that actually does tell us what is relevant in a referral. And there are also red flags, so it also sort of gives us an indication about what to be worried about and what not to be worried about.
Absolutely.
But the problem is actually, I'm probably talking to the converted here, but there are a whole lot of GPs that still don't know how to use health pathways, and so they don't. And that's why you get such crappy referrals.
And angry letters when they get rejected, and 4 referrals for the same problem, and because we write back to them and say this is why it's been rejected. It doesn't fit the criteria. I guess we probably should. Theoretically, I think if we had more time, we'd sort of actually attach the health pathway to that letter, saying this is why. We say it hasn't met the criteria for middle ear disease. Get an audio, get this, get that, do the CT, do this, do that. But it's all in the pathways, because I actually helped design those. So yeah, I know it's all there.
I'm just intrigued because we're starting to see a lot of throat cancers from SCCs, and I'm just wondering, how can we do the early intervention before you get the lymph node and the fungating tumour? And the first thing you think of is, can we adapt pap smears or whatever? I mean, there must be some way of trying to pick up that early stage.
Right, yeah, I think that's a challenge, because this is my impression, right? So the ones that go to their GP, every 3 months, and I've got this tiny, papilloma on my tongue that I've been looking at for, and I've seen the ENT surgeon. He said it's all clear, but I'm still worried about it, and can you send me back? And I see them again, 6 months later, and I'm seeing them every 3 years because I think there's something on their tongue, and they're the ones you're sort of seeing. And then we always get the ones in ED, turn up to ED. There's a lady who came in with a obstructing tumour, lost 9 stone in weight, and massive nodes, and you just think, well, I'm sure she hasn't seen a GP. I hope she's never seen a GP for it. But they're the late presenters. That's the challenge. So the ones that are going to their GPs regularly and getting regular 6 monthly reviews, and getting their blood pressure checked, and getting their they're the ones who've got the tinnitus and the globus and the sort of facial pain, and but the less the sort of lower socioeconomic fungating tumours are just hiding, I think, and then they present late, and that's the challenge. So, but yeah, I don't know what the answer is.
Mark, I've got a question here from our online audience.
Yes.
Are your referrals all coming from GPs, or is ED playing a role? And is it an education issue, which I think we've been talking about the past 10 or 15 minutes?
Yeah, look, the majority, we do get a few internal referrals, but, it's ED. I'm sure that, there's like specialist GPs, that sort of lovely interaction. I've just come from ED this morning, and I want to give a little story, because I came from ED. They rang me. One of my patients was there, and Andrew Crellin, the ED AO, said, "Come here and look at this screen." And he's showing me the screen. So there's 28 cubicles in ED, and he said, "All right, everyone with a red diamond next to their name is waiting for a bed." And of the 28 cubicles in ED, 22 had red diamonds this morning. So the ED's working with 6 beds, basically. That's what's happening. And so I said to Crello, "Right, I'm giving a talk to the GPs. What's the solution?" And then he just belted out, got it all off his chest. But because it's a sort of circular thing, isn't it? I mean, general practice under the pump. The patients, you can't get in to see the specialist, so you're sending them into ED, and then they're waiting in ED, and so of the 28, so I said, just show me what are those 28 people waiting. One was a guy who'd been in for 4 weeks and was discharged yesterday, and he's back this morning. Another one was someone had been there for 3 days, waiting for a bed. It's just this, and it's just I don't know what the answer is. I don't know. I really don't know what the answer is, but I know the ED people feel like they've been put under the pump a lot by the primary care, but.
We've got another question over here.
Yes. Yeah.
Hi, I'm coming from a totally different perspective, I think, but I'm a maternal and child health nurse.
Yes.
And when I see a mother and she sees her child snoring all the time,
Yeah.
I usually say, oh, you better go and see the GP. So, sorry, all you GPs. And say possibly, it's an ear, nose and throat problem. But should I be saying something else? Should I be having a sleep study instead? Is it a concern? I guess I just want to know what you're thinking.
Yeah. So I never do sleep studies. I never do oximetry. I think last time I checked, it's like a 3-year wait for a sleep study, for a paediatric sleep study in Victoria. They only do them at Monash, and they may do them somewhere else now. But it's a 3-year wait, so that's sort of a waste of time. And I just ask the parents, and we ask questions like, is the child falling behind at school? Are they falling asleep during the day? And often, I think, to be fair, parents usually say, oh, look, I've got 4 kids, 3 of them are always, playing outside, kicking the football, breaking glass in the neighbour's house and, getting run over and whatever and, breaking their arm on the monkey bars. And one just always lies on the couch and just is always the last one to eat, it's underweight, developmentally delayed, speech delay, and so I think, they probably do have obstructive sleep apnea and they need to be sorted. But again, I think the College of Paediatricians put out a consensus statement on sleep apnea, and I was at a meeting and I figured out that if every ENT surgeon just did tonsillectomies on children, they would not see any other patients. That would be every ENT surgeon in Victoria would just be doing tonsils every day. That again, it comes back to my first comment. It's a philosophical, social, political. Are we not training enough? Are we not? There's not enough support out there. It's a bigger problem. But I don't know if that answers the question. But
Can I ask you a question? What do you think
Yes.
about syringing ears? Syringing ears.
Yeah.
Should we be syringing ears?
All right. So, I'm not a big fan, but I understand that that's better than having 3,000 patients waiting to have their ears, the wax cleaned out of their ears, because that would be 7,500. I think if it was what I would love is if you got a voroscope, I think you'd be able to clean the wax out of the ears with very minimal training. We actually have a wax service in my rooms, so we employ an audiologist, and she works 2 days a week just to deal with the wax patients. So usually it's a context of someone that we've seen. They've got blocked ears, hearing loss, painful ears, otalgia, all the stuff we spoke about earlier. And they think it's their wax, and we show it's not the wax, but look, come back and see Rebecca in the rooms and she'll clean your ears out every 6 months and they feel happier with that. So, but I think with the voroscope, and as I say, very minimal training, you'd probably be able to teach the nurses or do it yourselves. But just to warn everyone, because the government have just are cracking down on this at the moment, the item number for ear toilet is really under scrutiny, and they're changing the criteria. So, because I think there's been an explosion in that use of that item number, it's gone up like I think 1,000% in the last 5 years. So the 41647, I think it is, or whatever it is, they're hot on that Medicare at the moment. So, there's a question? Yeah.
Just a quick extension on the very good last question. These kids with maybe large adenoids and large tonsils who are so chronic mouth breathers, you often see them and they snore. So how should we actually investigate them? Because I've referred quite a few of them, and they often then have their adenoids and tonsils done, and they're better after that. So how can you diagnose this without putting a scope up?
History and examination, You mean adenoids? Because tonsils you should be able to just see.
Yeah, no, tonsils.
So tonsils, you look and they've got kissing tonsils and you can't, it's stuck to the uvula and, clearly that's not a problem. So adenoids, I think, I'm not a big believer in isolated adenoid disease. So if you look in their mouth and they've got tiny tonsils, and you're doing, what we see a lot of is X-ray, lateral cephalogram and they say massive adenoids. So something like that. They say adenoidal hypertrophy, adenoid. They haven't got big adenoids. Like every time I see that X-ray, and if I look in their mouth and they've got small tonsils, they won't have big adenoids. That's my experience. But so I don't scope children. I never scope children. But I take a history. Like if they're mouth breathers, if they've got dry mouth, if they don't chew properly, they don't eat solid foods, they're always on the yogurts and the wheat bix and the pasta, and so it's history, and then the other thing you can do just to check for their nasal patency, I just get a metal tongue depressor and I just put it under their nose and I just check how it fogs. And if they've got big adenoids, you won't get good nasal patency, good nasal airflow. So I don't think I've ever scoped a child for adenoids in my career, so. Yes.
Hi, sorry. Quick question about nasal polyps in children, so not in adults.
Children,
yeah. So what's the first line?
Never seen it in a non-cystic fibrosis child.
Okay, so is that so in terms of someone that's had, the newborn screen and all of that, everything's been fine, what would you do in terms of first-line investigation as a GP?
Yeah, so I think the children that get sent with massive nasal polyps, almost always it's allergic rhinitis. You're looking at a massive turbinate.
Okay, right.
Yeah.
So treatment, and then if that's recurrent, would that warrant a referral?
So my pathway for allergic rhinitis is start off with intranasal steroids, and I tell every patient that you have to use it for 6 weeks. So, we had $1 for every time. They said, "Oh no, I've tried that." And I say, "How many days?" And they go, "I used it for 3 days." Or maybe it was 4 days. I say, "All right, well, 6 weeks minimum of intranasal steroids." If they've got massive turbinates, like you can't see the airway between the septum and the turbinate, I give them prednisolone. Now, the paediatricians have this freak out that how much prednisolone we're giving children, but it's a single dose. I give Predmix, 1 milligram per kilogram for 5 days. It shrinks the turbinate down, and then you actually got a chance of getting on top of it with intranasal steroids. But if you've got massive polyps, which is just a big inferior turbinate, you've got to shrink it down first, because these kids you won't get on top of it with just intranasal steroids off the bat.
Cool, thank you.
So cystic fibrosis is different. As I said, it's cystic. We see polyps in children with cystic fibrosis, but not in your average punter.
We've still got 5 minutes.
I've got another question. What do you think about laryngopharyngeal reflux? Do they need to see if it's classic of that?
Yeah, again, again, I'm not a super big believer in you mean for Globus, that Globus symptom that they, and usually the line is, I've been on the reflux tablets for 3 months and I've still got the Globus symptoms. So there are some who've got the classic, again, history and examination. So the big guy that looks like me, that's down at the pub, having 5 beers every night, and has got chest pain and indigestion and burping, and he's got laryngopharyngeal reflux to explain his Globus. But the very thin 20-year-old female that's very fit and well, and because I get it, and I tell them that reflux can be a cause of that Globus symptom. But when I scope them all, almost none of them have reflux. So I say, stop your PPI. Because my personal philosophy is it's not actually reflux. It's nasal. They've got allergic rhinitis and they've got hyperviscous mucus, and that's the theory. So you've got to actually attack the nose rather than the reflux. But as I say, it's history and examination. Like if they've got a classic reflux, I'm not saying no one ever has reflux and Globus, but they usually have a fairly classical history of reflux. Isolated lump in their throat is not the only symptom, is almost never reflux. in my experience.
It's Michael again. Just wondering, have you got any particular advice on how to administer nasal steroids?
Yeah, so I've got a little picture that I give every patient, and particularly this is really important for the children, is that I tell them they've got to aim for the outside corner of their eye. So the biggest challenge we have with intranasal steroids is more so with children, but children and adults, is they use it for a couple of weeks, then they get a nosebleed, then they stop intranasal steroids. So you're not trying to get the steroid onto the septum. If it hits the septum, it's going to dry the septum out and cause epistaxis. So you're trying to get it onto the turbinates. So I say aim up, out and back. And we actually have a picture, and I think you can get, I'm allowed to use brand names, but there's a sheet you can get from the suppliers of Flow that has got a really good picture of the direction you've got to put the nozzle to spray intranasal steroids. So it's got to go up, out and back. So I tell them aim for the outside corner of the eye. But the other thing I should declare is that I don't use intranasal steroids that much. I'm a big believer in using nasal douching with Pulmicort added, and I'm sure all the Ballarat GPs would probably know that I see a table of them over there, but just about every patient that sees me ends up leaving with a nasal douche with Pulmicort added.
How many vials? Like, what do you do?
Can
you tell us your recipe?
Yeah. So just one ampule of, I use 1 milligram per 2 ml of Pulmicort, and I put 1 ampule in per bottle, morning and night. So that's my preferred regimen for treatment of allergic rhinitis, because again, just with the question at the back there, massive turbinates, spray's not going to work. So I believe you need a douche, a nasal wash, and you need to get the steroid behind the inferior turbinate, the head of the inferior turbinate, and that's probably, I believe, why a lot of intranasal steroids don't help.
Can you repeat the recipe? Sorry.
I use Flow, but you can use Neilmed or Fess, the bottle. But you add 1 ampule of 1 milligram per. Pulmicort respules come in two strengths: 0.5 milligram per 2 ml and 1 milligram per 2 ml. It's an authority prescription, so again, that's a little bugbear because no one ever does this, but I always do an authority script. The streamlined authority code 6340, I know it off the top of my head. So,
and that's cheaper than the nasal steroids too, wouldn't it?
It's the same price. It's because and I can give them 6 boxes at a time.
Yep.
So one box of 30 with 5 repeats. So that's enough for 3 months using it morning and night. And that usually gets it under control, and then I tell them they can use it once a day or every second day, or they can taper it down according to their symptoms.
Excellent.
So Pulmicort ampules, 1 ampule, 1 milligram per 2 ml per bottle, morning and night.
Perfect. Thank you. One more question? Any more questions? I love these pearls of wisdom. They're gold. One. Oh. Okay. All right. I'm coming. Wait. I fell over at one talk when I ran.
And I'm not sure. I'll be interested in the GPs because I keep getting these calls saying they can't get it from their GP. I don't know. Like, is that something only specialists can subscribe? Or? Sorry.
Authorities it's probably restricted indication.
Is it? It's for asthma. Yeah, it's for asthma. Yeah. I'm gonna go to jail if you see me in the. 6340. It's now, when I go to ENT conferences, I remember 10 years ago, someone said, "Oh, try this Pulmicort," or some people putting Mupirocin, Manuka honey. It's one of those topics that keeps coming at every single ENT conference. I would say probably every ENT surgeon now uses Pulmicort in the nasal douche.
Hi, Mark. Eleanor Donnellan, GP in Port Fairy. Hi.
Just I love Port Fairy.
Thank you. Obviously, we're trying not to inundate Bridget Clancy in Warrnambool, as you mentioned. She does have a great YouTube channel with a video of her very obliging practice nurse showing the nasal sprays. That's a good resource for patients.
Yeah, it's great.
I just love these little pearls because I think all of us here in the room, we only want to send you the potential cancers and the really serious pathology, especially in the country. We love being able to do more and we love a quick fix in the rooms. It's much more satisfying to get some wax out than to hold someone's complex psychosocial trauma often. So just with the syringing, obviously at the moment we don't have microsuction technique stuff in our rooms, but I'm just wondering as a practice owner if it's something I should invest in. So with the voroscope, do you also use the microsuction, or do you just
not
under
much.
direct vision with the wax curette?
With the wax curette, yeah. And you know, we use disposable wax curettes. I think they're like, you know, 10 cents each or something.
We
so
have
it's
those.
not a massive outlay. But yeah, I don't use suction much. I use suction for otitis externa. You know, I use it for fungal disease in the ear because they've been on drops for 3 years, you know, antibiotic drops. So, you know, I don't feel like I come here and I give you all my little bugbears, but, so you know, so I don't use the suction that much. I don't use suction for wax. Let's put it that way. Usually there's a pathology for me to have to pull out the sucker. Sort of a hassle to pull out the sucker. It takes, you know, 10 seconds extra. So. So I generally just use the wax curette, but the vision, having the voroscope will change. You know, like I'm not even an ambassador. John should be paying me, but I think it's a real game changer for ENT because you know that's sort of the secret, if you like. That's why we can see stuff no one else can see. It's just the voroscope. So.
Well, thank you, Mark. I actually think that was so good, as you say, to get those pearls. I think we've taken a lot from today, so really, really appreciate your time. We will finish up now, and I want to thank Mark.